my name is Ellen Aslan. I am a fourth-year medical student at UC Davis School of Medicine. I want to thank Dr. Schick, who was my mentor throughout this process. Topic today is building consensus for global health tracks and emergency medicine residencies. The International EM Fellowship Consortium lists 30 plus global health fellowships, 7 of which are SAEM accredited. While many residencies offer global health tracks, there's no process for accreditation or standardization of these global health tracks and residencies. So we wanted to establish a consensus for the core curriculum topics to include in an EM global health track. We used a Delphi survey method, which was essentially a series of successive surveys built on the feedback from the round before. We had 2 rounds. Round 1 included topics and asking participants to rank these topics as essential or non-essential, and then provided a free text response. And then round 2 asked participants to rank the topics identified as essential in round 1 on a 1 to 5 Likert scale. For round 2, we used a greater than 70% agreement of strongly agree or agree that the topics were essential as the threshold for consensus, which is consistent with other Delphi survey studies. For our survey development, we used the proceedings. So for the identifying global health topics to include, we used proceedings from 2011 Cord Global Health Specialty Track Academic Assembly, an implementation guide for pediatrics residency directors that has already been published, and then reports on status of the global health programs at individual EM institutions. For our expert recruitment, we used information that was freely available on institutions who are involved in global health tracks. We used an attendee contact list from the African Conference on Emergency Medicine, authors of several publications who were involved in the development of EM global health track programs, and then personal contacts of my mentor at UC Davis EM department. So we had 23 participants from 15 institutions in 6 countries, as seen below. For round 1, 14 topics were considered essential. So greater than 95% of participants ranked these specific topics out of 87 topics as essential. So we can see that the top 2, barriers to health and healthcare in low resource settings, and adapting emergency medicine skills and practice in low resource settings were unanimously considered essential. Other topics that were ranked highly include role of NGOs and governmental organizations, ultrasound, infectious disease, and conducting a needs assessment. The remainder are seen here. For round 1, we also received free text responses, and importantly, quite a few of them emphasized the importance of institutions self-identifying as focusing on short-term projects versus long-term global health projects, which would direct the path of how it should implement this curriculum. So for round 2, we asked participants to rank the topics that were considered essential in round 1. Again, the top 2, barriers to health and healthcare in low resource settings, and adapting EM skills and practice in low resource settings were considered essential. 100% ranked on the Likert scale ranked these 2 topics either 4 or 5 out of 5, which is in the left-hand column you see percent agreement, and then percent strong agreement on the right-hand side was 5 out of 5. Importantly, we correlated these results with, we asked all participants to self-identify whether the institution tended towards short-term or long-term projects, as we received from the free response in round 1. And we found that this significantly correlated with their responses to these 3 topics. So those institutions who identified as focused on long-term projects ranked these 3 topics significantly higher. The 2 that were identified as unanimously essential, and then infectious disease as well. In the free response for round 2, the free response was mostly focused on the importance of individuality and personal relationships in global health programs. For this discussion, we reached greater than 70% consensus in 2 survey rounds. We found that there's an inclination towards long-term projects significantly correlated with evaluation of infectious disease. Some limitations for this study were that we had quite a few closed-ended questions in round 1, which is not typical for a Delphi survey, but we found that we had a wealth of topics to choose from several different sources that we found. Also, there was an arbitrary thresholds, it always invites bias, but this is inherent to a Delphi survey. And we found that since we set the threshold before data collection, we tried to limit that bias as best we could. We also acknowledge that the survey pool that we received feedback from may not be representative of everyone who's attempting to develop a global health track residency or a global health track and EM residency, as many of the participants heralded from Western countries. We found that future research could focus on the implementation of this curriculum and also learner-centered outcomes. So ultimately, we found that we found a consensus on less than 15 topics for core global health track curriculum topics. Individual institutions should decide on short-term versus long-term projects when they're starting out. And then future research should be focused on determining the efficacy of longitudinal versus compact coursework. Here are references. Thank you so much for watching, and I look forward to answering your questions.
Hello, my name is Austin, and I want to thank you for joining for this oral abstract entitled Derivation of a Continuous Model for Volume Deficit in Patients Over 5 Years with Acute Diarrhea. I'd particularly like to thank my co-authors and collaborators on this project. I'd like to note we have no conflicts of interest to declare, although the project was funded by an NIH grant. So diarrhea causes dehydration through volume losses. It's a major cause of morbidity and mortality around the world and annually leads to about 1.3 million deaths. The diarrheal burden is unequally distributed around the world, and it's particularly high in low and middle income countries. They often have fewer healthcare resources. And existing care algorithms, particularly from the WHO as well as from others, really look at categorical estimates of dehydration as none, moderate, or severe to target their treatment decisions. However, it would be ideal if one could instead say, in this individual patient, I know that they are this dehydrated, they have this percentage dehydration, to then calculate the fluid deficit that you would need to give back to the patient. So for example, if you had a patient that was 50 kilograms and you knew they were 5% dehydrated, you would know I need to give back to this patient 2.5 liters to make them euvolemic. So the objective of this project was to develop a multivariate model that could accurately predict the fluid deficit or the percentage dehydration of patients with acute diarrhea. No current models exist, and so we were hoping to derive one from the data that we have. So we were hoping to really, in the end of it, develop a tool that healthcare professionals could use in a variety of settings to both triage, but also treat accurately their patients who have acute diarrhea. We performed a secondary analysis among a prospective cohort study of patients who presented with acute diarrhea to the ICDDRB Dhaka Hospital. Participants were recruited 24 hours a day, 7 days a week, from March 2019 to March 2020. Patients who arrived to the rehydration unit who had symptoms of dehydration and diarrhea and were aged at least 60 months were randomly selected for screening. Consecutive enrollment wasn't feasible because of the volume of patients that arrive every day to that care unit, sometimes upwards of 200. So we had to randomize screening before enrollment. So after patients were enrolled and consented in the local language, they were weighed and then assessed by 2 different clinical staff. Patients were re-weighed throughout their visit every 4 hours until they obtained a stable rehydration weight. The assessment on clinical predictors, there were 16 of them, was performed by 2 blinded research study nurses who were trained in methods, but effectively made their assessments based on the patient's presentation. And then all patient care and management decisions were according to the standard ICDDRB protocols for dehydration and diarrhea. Modeling methods that we used included forward stepwise regression to fit the predictors, and then the performance of the model was assessed using the mean squared error. Very few patients were missing data, and so listwise deletion was used. Additionally, the reliability was assessed by comparing the model predictions to each assessment using the interclass correlation coefficient. We also used bootstrapping to correct for overoptimism. So a total of 4,440 patients 5 years and up presented during the study period for random screening, and of those, 2,172 were enrolled. The median age was 35 years, and of those, just about 50% were female. The best performing model had 7 predictors. Those included age, sex, skin pinch or skin turgor, the systolic blood pressure, the mid-upper arm circumference, the sunkenness of the eye level, and the number of vomiting episodes in the past 24 hours. The MSE was 6.99 with an adjusted R-squared of 0.28. The interclass correlation coefficient was 0.93 with a very narrow confidence interval. The average optimism corrected MSE across those bootstrap iterations was 7.4. What we can take away from this is that the predictors included in the model can be obtained by healthcare workers with minimal training. The assessment of skin turgor, blood pressure, and the mid-upper arm circumference are data points that could be collected, not necessarily by nurses, but even by lesser trained or less skilled healthcare workers in a variety of income, low and middle income settings. We also were able to derive the first continuous model looking at volume deficit in patients with acute diarrhea. The assessment of the percentage dehydration in the fluid deficit matters because it allows us to provide targeted treatment. The fluid resuscitation can be much more accurate than existing categorical models. Really, the aim is to avoid the sequelae of overhydration or underhydration in patients with acute diarrhea. This was a derivation study, and so in the near future, hopefully in the next few months, but probably in the next year, we will be able to collect the validation data set to reassess if this model is accurate. I'd be happy to answer any questions. Thanks so much.
Hi, everyone. My name is Sarah Bridge. I'm the third-year emergency medicine resident at the University of Virginia, and I'm very pleased to present my research at SEM this year. I'm going to talk about a study that I did in 2016 and 2017. Where I evaluated the BioFire film array meningitis encephalitis multiplex PCR panel in Uganda. So a little bit of background about our study. So meningitis, and particularly cryptococcal meningitis, causes significant mortality in sub-Saharan Africa, and limited diagnostics exist. We evaluated the utility of the BioFire film array meningitis encephalitis multiplex PCR panel, also known as the film array ME, in HIV-infected adults and HIV-infected and uninfected children presenting with suspected meningitis in Uganda. So our study took place in Kampala, the capital city, and in Mbarara, which is in the southwest part of the country. Most of my work was focused in Mbarara, and as you can see on this map here, it's down kind of by the border of Rwanda and Congo. So this is a picture of the Mbarara Regional Referral Hospital. This is the second largest academic hospital in the country and was one of our main study sites. So for our methods, we tested CSF using a stepwise diagnostic algorithm, including film array. We determined the diagnostic performance of film array for cryptococcal meningitis using cryptococcal antigen, also known as CRAG, and CSF culture as reference standards, and assessed other CNS pathogens identified by the panel. We also assessed the advantages and disadvantages of using this panel in our setting. So this is a diagram of the panel. It's a simple, easy to use panel. It requires only about 2 minutes of hands-on time. So essentially you take a pouch of the multiplex PCR reagents, load that into a dock, inject a hydration solution, and then inject about 1 milliliter of CSF sample. And then you plug that into the film array instrument and then set it and forget it, essentially. About an hour and a half later, you will get a printout of your results, and the instrument targets 14 pathogens in CNS sample, which are listed here. So for bacteria, it tests for E. coli K1, H. flu, Listeria, Neisseria, Strep A galactiae, and Strep pneumo. For viruses, it tests for CMV, enterovirus, HSV1 and HSV2, human herpes virus 6, human precovirus, varicella zoster virus, and then it also tests for Cryptococcus neoformans gattii, which was the central pathogen in our study. For our results, we evaluated 258 adult and 42 pediatric CSF specimens using film array. For Cryptococcus, sensitivity was 82%, specificity was 98%, positive predictive value was 98%, and negative predictive value was 79% in specimens using CSF CRAG as a reference standard. Overall sensitivity was decreased at low fungal burdens, 29% for 0 to 9 Cryptococcus colony forming units per ml, compared to 94% for greater than or equal to 100 CFUs per ml in diagnostic specimens. Other pathogens detected included E. coli, H. flu, strep pneumo, CMV, enterovirus, HHV6, and VZV. Of the pediatric population, 2 specimens tested positive, one for strep pneumo and one for Cryptococcus. Advantages of the panel included ease of setup and use, minimal CSF processing, and multiple pathogen targets requiring a small sample volume. Disadvantages included cost, difficulty servicing the instrument in case of breakdown or repair issues, inability of the panel to detect pathogens commonly associated with HIV, such as M. tuberculosis, Toxoplasma gondii, and JC virus, and operating the instrument on an inconsistent power grid requiring creation of a universal power supply, also known as a UPS, using 2 24-volt car batteries and a sine wave inverter. And I've got a picture of that on the next screen. So in Uganda, and very commonly in Mbarara, there would be citywide power outages that could happen at any time. If these power outages occurred during one of our CSF sample runs, it would essentially ruin the sample and we'd have to start again. To get around this, we created a universal power supply by hooking up these 2 big car batteries to a sine wave inverter and then connecting that to the instrument, thus creating a universal power supply. So if there was ever a cut in the central power, the hospital power supply, this would automatically switch over to the car batteries and continue to power the instrument so that no interruption in the run would happen and the run could go to completion. So in conclusion, multiplex PCR is a promising rapid diagnostic test for meningitis in adults and children in resource-limited settings. FILMARRAY-ME had poor sensitivity for Cryptococcus at low fungal burdens. It should not be used as a standalone test for Cryptococcus, but it may be helpful in differentiating febrile illness in children living in areas with high malaria and meningitis prevalence. Reducing its cost, adding M. tuberculosis and HIV-associated pathogen targets, and including a UPS would be optimal. And I will take some time for any questions. Thank you so much for having me at SAM this year. It's truly a pleasure.
Hi, my name is Alex Monroe, and this is my abstract titled Estimating the Weight of Children in Uganda, Comparing the Broslow, Popper XL-MAC, and Mercy Methods. I completed this project when I was a Pediatric Emergency Medicine Fellow at the Medical University of South Carolina. Currently, I am an assistant professor at Emory University in the Departments of Emergency Medicine and Pediatrics. I have no financial relationships or disclosures. So the background of this project hinges on 4 key tenets. The first is that for children less than 40 kilograms, nearly all medication dosing and intervention is based on their weight. Often in the emergency department, it is not feasible to measure a true weight on a scale due to the acuity of conditions, necessitating weight estimation techniques. In low and middle income countries, there's often limited access to scales, both in the community and the hospital setting, further complicating this problem. And historically, both parents and providers have had poor visual estimations of weight. These issues are further complicated by the double burden of undernutrition in low and middle income settings, where large portions of the population suffer from wasting, stunting, and micronutrient deficiencies, and there's a growing portion of the population that suffers from the obesity epidemic, which creates a non-normal distribution of pediatric weights in these areas. In the past, there have been 4 main types of pediatric weight estimation. The first is parent or provider visual estimations. Next is formulas, usually based on age or other metrics. Most commonly are one-dimensional tools like the Broslow tape, which use length to create an estimate. And more recently, 2-dimensional tools which incorporate a measure of body habitus, usually a mid-upper arm circumference, have hit the market, including the Popper XL-MAC tapes and the Mercy tapes. Our hypothesis was that 2-dimensional tools that account for body habitus would be more accurate than length-based tools when used in rural Uganda. Our study design was an IRB-exempt QI project in partnership with One World Health at their 4 clinical sites in Western Uganda, in Masindi, Wayali, Bulima, and Kijunjubwa. Data was collected between December 2019 and March 2020, but terminated early due to COVID-19. Subsequently, we completed an IRB-approved retrospective cross-sectional review of our QI data, which is presented here. Data was collected on 0 to 14-year-olds presenting to vaccination clinics at the 4 clinical sites. We excluded patients that were pregnant, had contractures, dwarfism, or happened to be taller than the maximum height of the tapes. We collected weight estimations and scale weights on children with a single layer of clothing on and no shoes. And we uploaded our data weekly to a secure server via RedCap. Our primary endpoints focused on percentage error, with mean percentage error being our measurement of bias, root mean squared percentage error being our measurement of precision, and the percentage of estimations within 10% and 20% of the true value being our measurement for accuracy, with a test being determined as accurate if it met predefined standards of a PW10 greater than 70 and a PW20 greater than 95%. For our data, we measured 621 children with an average age of 1.17 years and an average weight of just over 9 kilograms. Notably, about 85% of our population fell into the less than 12 kilogram subgroup. For primary endpoints, the Broslow tape and parental estimate tended to underestimate a child's weight, whereas Mercy and the Popper XL MAC tapes tended to overestimate children's weights. When it comes to accuracy, both the Popper XL MAC and parental estimates had high performance for PW10 and PW20. However, neither met the predefined standards of greater than 70 and greater than 95% respectively. We also created modified Blaine-Altman plots, which plot the percentage error versus the true weight for each method. Here we are able to visually appreciate the clustering of data in the lower weight subgroups, as well as the degree of variability and error in this subgroup with a trend towards convergence as weights increase for all estimation methods. The strengths of this study include the fact that it's performed in typical low or middle income clinic settings with limited resources, whereas prior studies had mostly been performed in large urban academic tertiary care centers. We also used typical staff to take our measurements rather than specialized providers. Limitations include its retrospective design, early termination, and biasing towards the less than 12 kilo subgroup. This is in large part due to our targeting of vaccination clinics, but highlights the fact that small absolute errors can lead to large percentage errors when the denominator is small, as in small children. In conclusion, while the Popper XL MAC tape had higher accuracy than its competitors, none of the tools met acceptable accuracy standards for weight estimation. Additional research is needed to create practical and accurate weight estimation tools for emergency use in rural Ugandan children. Finally, I'd like to send a special thanks to my co-authors and Scholarship Oversight Committee at the Medical University of South Carolina, as well as my on-ground coordinators, Joyce and Sylvia, who were pivotal in the success of this project. Thank you.
Hi, my name is Derek Tin. I'm the Senior Fellow in Disaster Medicine at Harvard Medical School. Today I'll be talking to you about terrorism-related CBRN attacks and a little bit about counter-terrorism medicine. I have no financial disclosures. So since the 1970s, there's been about 160,000 terrorist attacks. In 2014, we saw a peak in terrorist activity with over 40,000 associated deaths that year. So we decided to do a study on terrorism-related CBRNE events and look at some of the historic WMD threats. The data was collected using a retrospective search of the Global Terrorism Database. This is an open access database maintained by the National Consortium for the Study of Terrorism, and is generally regarded as the most comprehensive database of its kind. The study period spans from January 1st, 1970 to the end of 2018. Now, different definitions of terrorism exist, and we use the GTD's codebook definition. Ambiguous events were excluded, and it's also worth noting that state-sponsored terrorism events are not included. We found 390 CBRN events during the study period, which accounted for less than 0.3% of terrorist attacks, so relatively rare. And if we break this down by modality, you can see that chemical weapons dominate is the dominant choice in 347 events, which is 88% of the cases. Biological weapons were used in 31 cases and radiation in 12 events, which account for 8 and 3.1% respectively. There were no recorded nuclear events. In total, 930 fatalities were recorded with over 14,000 non-fatal injuries. Now, if you look at it in the pie chart, you can see that the chemical attacks dominate the fatalities, but obviously keeping in mind the heavy bias in chemical weapon use as well. And this is similar for non-fatal injuries. But what is really telling is when you look at the mean number of injuries per event by weapon type, you can see the obvious spikes in chemical and biological weapons, the injuries related to chemical and biological weapon use. Now, looking at chemical weapons, the Taliban was implicated in 40 of the 347 chemical events. Water supply terrorism is well documented in literature. The use of corrosive acid is also a tried and tested method across the world. Now, whilst there's no hard evidence of the use of white phosphorus, gray literature suggests it is one of the many chemicals weapons that the Taliban experimented with. The Tokyo sarin gas attack remains one of the most discussed case study, with over 5,500 non-fatal injuries with sarin gas. But we know that the cult had been experimenting with VX, phosgene, and hydrogen cyanide even before that event. The 2001 anthrax attacks, probably one of the more sort of infamous biological attacks, also known as Amerithrax, killed 5 and infected 17 after a series of letters containing anthrax spores were mailed to several news media officers and politicians in the US. Radiation attacks were very rare. The 10 cases of monazite came from Japan. In the year 2000, the Japanese Home Affairs Ministry in Tokyo received envelopes laced with monazite, which contains radioactive thorium. And that was sent to them by a disgruntled citizen who wanted to warn the government officials about the illegal exports of uranium to North Korea. So the traditional Achilles heel of disaster medicine is really trying to convince people to invest time, energy, effort, and money into something that may never happen. And CBRN falls squarely into this so-called low frequency, high acuity event type. It is, however, important to remember that terrorism isn't just about killing lots of people. The psychological and financial repercussions of these events are often disproportionate to the physical injuries they cause. Take the anthrax incidents that killed 5 and injured 17. The estimated cleanup cost, medical cost, and decontamination cost was in the region of $800 million US. Terrorism events have a distinct difference to other man-made disasters. Whilst most man-made events take into account the safety measures to minimize impact in case of a disaster, terrorist events have the opposite mantra. They are designed to maximize death and destruction, and we need to be half a step ahead in order to mitigate the healthcare risk that comes along. And this has really led to the emergence of counterterrorism medicine, a disaster medicine subspecialty that focuses on the healthcare risks of terrorism-related mass casualty events. We identify deficiencies in our medical responses. Toxidrome recognition is a good example. We published a quick and easy to use algorithm where none existed previously. We look at historical events and analyze differences in suicide versus non-suicide bombing, enclosed versus open space explosions, look at biological outbreaks and analyze their potential to be used as a biothreat, for example. And we're also very forward-looking. How can rogue actors repurpose agricultural drones to release harmful chemicals? What's the black market availability of fentanyl derivatives similar to the one used in the Moscow theater siege? How does the recent cyber hacking of the Florida dam change our strategies in terms of water supply terrorism? Counterterrorism medicine isn't just about medicine. It's a much needed collaboration between security, defense, police intelligence, and health. And CTM aims to bring this conversation to the forefront of discussions. Thank you.
Hello, my name is Dr. Jonathan Siegel. I'm an emergency medicine physician and serve as vice chair at New York Presbyterian Queens Tertiary Care Center with pre-COVID volumes around 120,000 patients per year. And I'm here to discuss with you an abstract regarding a exertional hypoxia and virtual follow-up in emergency department patients that were discharged with COVID-like illness. We're describing a pathway we used in the early initial COVID-19 surge. To give some background on the situation at the time this pathway was launched, it was mid-March 2020. New York City was an early COVID-19 epicenter. Many of you may recall that testing was very limited early on, which restricted our ability to do testing rapidly in ED. Initially, COVID-19 testing was restricted to the Department of Health, and there was prolonged turnaround times, 12 to 24 hours. So it was not really used as a decision rule in the ED early on. There was concerns for ICU space and especially ventilator availability, many of you may recall. And there was a lack of information about a benefit for intravenous medications like we have now for monoclonal antibodies, remdesivir, or dexamethasone. During that time, in the third week of March 2020, New York City was seeing exponential increase of COVID-19 patients. New York Presbyterian Queens ED, where I happened to work, hit a high point of 208 boarding inpatients in the ED, which is 4 times the licensed bed capacity, and about 4 times as much as we've seen in an average flu surge in prior winters. We had some observational reports from Italy showing that COVID-19 patients were desaturated with exertion. And so we made a decision to operationalize exertional hypoxia as part of a ED disposition pathway for and telehealth visit pathway, which I'm going to show you on the next slide. So here's the pathway that was created for New York Presbyterian hospitals, launched on March 25th, 2020. It divided ED patients into 3 categories. If you presented with COVID-like illness, mild, moderate, and severe. Mild were discharged with standard precautions. Severe were admitted. Moderate, the goal was to discharge with pulse oximeter, and for the most hypoxic, 90 to 91%, exertional sats to be given an oxygen concentrator as well, with telehealth follow-up to be arranged within 24 hours of discharge, and frequent telehealth follow-up calls after that for 7 days post-discharge. The goal was to care for this group at home while carefully monitoring and watching for any signs of a need for hospitalization, in which case to advise patients to return to the ED. Okay, so the abstract represents an analysis of those patients who were in the moderate COVID-like illness category and were discharged from the ED. We had 677 total patients that were analyzed. They enrolled in a virtual follow-up and remote patient monitoring program. A subset was initiated in supplemental home oxygen, and data was collected both from the ED first visit, which we call the index visit. Follow-up visits were done with virtual care, and ED return visits, all collected from similar EMRs from New York Presbyterian hospitals. Outcome data was collected retrospectively from six participating hospitals. Results: we had 677 total patients enrolled. Again, each one of these patients was given a pulse oximeter and instructions to use directly from the ED. 28% were given 28.7% were given oxygen concentrators directly from the ED for home use as well. Median resting versus exertional O2 saturation was 95 versus 93, so you see a median of 2% drop in SpO2 in resting versus exertional. Virtual follow-up was completed 86.6%. Some patients chose not to participate. Some patients had returned to other EDs already, but we had a fairly high completion rate for at least one virtual follow-up of 86.6. We had 20.4% of patients in this moderate COVID-like illness cohort did return to EDs within 7 days. 12.7 total were returned and admitted. And the 30-day mortality, we followed up to 30 days, was 1.9%. Loss to follow-up was 5.3%, and this includes a look up to 90 days through EMR and calling patients to through follow-up. Patients who were started on home oxygen had similar return and mortality rates to those with virtual follow-up only, despite exertional hypoxia and index visit. So the ones who had a median of 91% exertional sat and were given oxygen had similar return and mortality rates. One more graph here, just to I believe it shows an interesting graphic that many of us have seen with COVID, and that is that deterioration doesn't necessarily happen in the first couple of days. If you look at the graph in days of symptom onset up to 14 days, there's similar ED return and admit and ED return rates. So if a patient shows up on day 11, 12, 13 after symptoms have started, and you discharge with, as a moderate illness patient with follow-up arranged, they're not necessarily at a greater chance of not returning to the ED. So wanted to share that. Conclusions. I think the more novel part of our pathway was using exertional saturation as a decision tool, both in the ED and telehealth. Prior to this, many of us had not had a patient, walk in place or walk around the ED for 60 seconds and do the sat and then do the same thing during a telehealth visit. It was widely adopted. We found it to be useful. This is a descriptive study, so in the future, hopefully there will be a more powered study doing a statistical analysis. Thank you very much and enjoy the rest of the conference, everybody. Thank you.
Hello everyone, my name is Jenna Palanch and I'm one of the senior residents at Carolinas Medical Center, Atrium Health. Today I will be talking about the project COVID-19 Effects on Intimate Partner Violence, Sexual Assault, and Child Abuse in the Emergency Department that I conducted along with Drs. Milam, Manning, Kopek, Salzman, and Lewis. We have no financial disclosures. While we've all been inundated with statistics regarding the pandemic, and many of you are likely very familiar with these numbers, we know that the COVID-19 pandemic has had catastrophic spread and that social distancing has been demonstrated to be a necessary component to mitigating this disease. This has been enforced through a series of de-escalating national, state, county, and city stay-at-home mandates and social distancing restrictions. We also know that social distancing and lockdowns pose an increased risk to some of our most vulnerable populations, namely those at risk for or currently experiencing intimate partner violence, sexual assault, child maltreatment, and elder abuse. Previous literature has demonstrated an increased risk of these violent crimes during other types of natural disasters. Social isolation and financial stressors also increase the risks of violence and abuse. However, despite this increased risk, resources can be more limited in times of national crisis, which we experienced locally with several advocacy centers briefly de-escalating their services or even closing for a time. Additionally, for those of us practicing in the emergency department, there seems to be a subjective increase in patients presenting with these complaints despite total decreased emergency department volumes. Our study aimed to describe emergency department visits for intimate partner violence, child maltreatment, and sexual assault in the setting of social distancing and the COVID-19 pandemic within our community. To do this, we retrospectively examined the total number of calls, consults, and visits for several pre-hospital, hospital, and community resources from March 1st, 2020 to October 31st of 2020. We compared these values to the same time period of the previous year. Hospital resources were taken as a percentage of total visits to account for fluctuating volumes, and our results were analyzed with Wilcoxon rank sum and chi-squared tests with a p-value cutoff of less than 0.05. To analyze our pre-hospital data, we obtained information from Charlotte-Mecklenburg Police Department Dispatch and Medic Emergency Medical Services Dispatch. For hospital visits, we obtained data from consult services provided by our Domestic Violence Health Prevention Team, Sexual Assault Nurse Examiners, and Child Protection Team. We also queried emergency department visits with ICD-10 codes specific to intimate partner violence, child maltreatment, and sexual assault. To examine resource utilization in the community, we obtained call logs and referrals to Safe Alliance, a nonprofit Charlotte-based organization that provides resources for victims of intimate partner violence and sexual assault, as well as Pat's Place, a child advocacy center assisting those experiencing or at risk of child maltreatment. What we found when looking at our CMPD dispatch data was a statistically significant increase in pre-hospital reports of these types of violence, with an average dispatch of 5,219 in 2020 compared to 4,953 in 2019. We found that across both time periods, those at highest risk were young, age 18 to 29, Black females. After analyzing data from CMPD, we found that there were very minor changes in the types of violence seen from 2019 to 2020, such as increases in the number of gun threats and verbal threats. Our local EMS agency data unfortunately does not code for specific types of violence with the exception of strangulation, which did increase in 2020 compared to the previous year. In looking at our hospital resources, we found an increase in the percentage of total ED visits requiring SANE and DVHP consults for sexual assault and intimate partner violence. This was statistically significant only for DVHP within the first 3 months of the pandemic. However, when looking across the entire time frame, was no longer a statistically significant difference. Our child protection team saw consistent and significant increases in consults across all months during the pandemic in 2020 compared to 2019. In reviewing emergency department visits with ICD-10 codes specific to these types of violence, we found significant increases in the percentage of visits coded as child maltreatment and intimate partner violence, along with increases in visits coded as sexual assault. However, this was not statistically significant. Despite these initial findings of similar or higher rates of violence in the pre-hospital and hospital settings, we saw decreased calls and consults to our outpatient resources. Safe Alliance received fewer calls on average in 2020, with the exception of the months of June and October. And similarly, Pat's Place had decreased referrals in 2020, with 2 exceptions in August and September. Pat's Place was shut down for several weeks at the start of the pandemic in March, but this does not fully explain the continued decreased referrals over the next several months. Overall, our study demonstrated similar rates of sexual assault and increased reports of intimate partner violence and child maltreatment during the COVID-19 pandemic compared to the previous year. Despite this, there were fewer calls and referrals to advocacy centers within the community. Our study had several limitations, several of which were that we were unable to account for a certain group of patients with ED visits that were not given diagnoses that were specific to intimate partner violence, child maltreatment, or sexual assault. However, as we use the same ICD-10 codes from 2019 to 2020, we are under the assumption that we would be missing the same general pool of patients. Similarly, we do know in review that a small percentage of visits falling under the category of intimate partner violence actually encompass elder abuse, although we consider this to be relevant as both groups are at increased risk with social distancing. In conclusion, further research is still needed to describe the relationship of interpersonal violence, social distancing, and natural disasters such as pandemics. Our study emphasizes the importance of considering these populations in disaster relief and hospital planning. In addition, our study highlights the need for increased outreach and unique mechanisms to provide care for these vulnerable populations that are experiencing higher or similar rates of violence, but with limited ability to seek help. Special thanks to Drs. Patricia Morgan and Dr. Kendra Ham with our child protection team and Jessica West with EMS. Thank you all for listening, and we'll take some questions.
Thank you for the invitation to share our work at SAEM. I'll be presenting on behalf of the Region 1 RDHRS telehealth team. Our core partners are from Boston Medical Center, MGH, Brigham and Women's Hospital, the Northeast Telehealth Resource Center, and Blue Stream Health. Today, I'll present the results of a field test of the Regional Disaster Telehealth Platform prototype during the COVID-19 pandemic in Massachusetts. This project was funded by the Office of the Assistant Secretary for Preparedness and Response, or ASPR. In 2018, ASPR funded 2 national pilot projects, one in Region 1 in Massachusetts and Region 7 in Nebraska. In 2020, Region 8 in Colorado was added to the RDHRS program. These pilot systems are designed as models to improve healthcare disaster readiness and response, with the ultimate aim of having a more capable and better coordinated and supported healthcare system across the nation. As one of the 2 initial primary award recipients, Massachusetts General Hospital in Boston spearheaded the creation of the RDHRS in Region 1. The Region 1 RDHRS includes participants from 17 tertiary care hospitals, all 6 state public health departments and coalitions, as well as numerous other specialty organizations. For the telehealth division of the RDHRS program, our prototype system model leverages a national registry of expert volunteers that can be rapidly activated and virtually deployed to support field site clinicians at the point of need. In this model, field clinicians requesting assistance are connected to remote experts via a simple self-guided web portal as the prototype telehealth platform. Experts are recruited from national societies of disaster-relevant specialties, such as American Burn Association and the Society for Critical Care Medicine. The primary objective of this pilot study was to field test the acceptability and feasibility of using the prototype system to provide peer-to-peer, on-demand, telehealth ICU consultation for COVID-19 response in Massachusetts. We recruited out-of-state critical care physicians from the Society of Critical Care Medicine as subject matter experts. Experts were trained to use the prototype RDHRS platform. We also recruited field clinicians at Massachusetts hospitals. Field clinicians received a just-in-time tool for self-guided platform use without prior training, as this is critical for disaster applications. Field clinicians could request teleconsultation for hospitalized COVID-19 patients or simulated patients on demand during a 15-day pilot period in June of 2020. We collected demographic and call performance data. We used the telehealth usability questionnaire to assess the domains shown here on a 7-point Likert scale. The primary outcome was acceptability, measured by the total usability score. Secondary outcomes related to feasibility were measured by interface, interaction quality, and reliability domain items. This slide depicts the workflow used to connect field clinicians to an expert via the prototype platform. This simple HIPAA-compliant system could be accessed from any location with an internet or cellular connection, using any device with a camera and microphone capability. 10 experts from 6 states and 17 field clinicians from 4 hospitals participated. All had over 5 years of clinical experience, and only 20% had used telehealth in a disaster. This graph depicts the timeline from prototype construction to the start of the pilot. In February of 2020, the prototype system was still only a concept. As COVID-19 cases rose, we fast-tracked prototype platform development by engaging a technology partner. By April, we had recruited experts and field sites. However, it took 6 weeks to navigate barriers in licensure, credentialing, and liability protection, despite federal and state disaster provisions. By the time we were ready to start, cases had declined substantially, ultimately resulting in no clinical use. However, by using a test call strategy, we were still able to test the prototype platform and model system by simulating real-world use. There were 50 test calls logged. 70% of the field clinicians were able to make more than one call. The median time to connect to an expert was 1.6 minutes. Surprisingly, only 22% of the calls attempted were successful. We examined the reasons for call failure along each step in our workflow. Over half the failed calls were due to a call routing error at one hospital. Expert notification errors, use of hospital computers lacking cameras or microphones, and hospital information system firewalls were less frequent causes of call failure. This is the telehealth usability questionnaire. The mean total usability score was 5.6, with a standard deviation of 1.3. Items in usefulness, ease of use, and satisfaction domains scored the highest, and reliability regarding error messages scored the lowest. In summary, user acceptance of the RDHRS disaster telehealth system was high. We found the prototype platform was useful and easy to use. Field clinicians were able to connect with experts on demand using a simple web-based platform with no prior training. I can also report that by targeting the key reasons for call failure identified in this field test, the revised prototype has improved call performance and reliability. Overall, the lessons learned from this pilot field test have been instrumental for the ongoing development and real-world implementation of the RDHRS telehealth system in Region 1. A large, multidisciplinary, multi-organizational team contributed to building this complex system, and I would like to acknowledge current and prior contributors to this effort. Thank you.